I will be giving you updates in stem cell transplant and multiple myeloma, and following, one of my colleagues, Dr. Luciana Costa, will give you updates on clinical treatment in multiple myeloma excluding transplant. These are my disclosures. So I broke this talk up into 3 sections because there's a constant question about how to use autologous transplant in the era of novel and now even noveler agents. So we'll discuss what we know about transplant in myeloma, what we still question, which is why are we still doing transplant in the novel era? When should we do it? Should we do it in upfront therapy or delay until the time of relapse? And who should have a transplant? There are several things that we still need to figure out about transplant. There are some known barriers to stem cell transplant. And for the sake of time, I won't talk about the multiple therapies that are used for relapse refractory disease. That's likely going to be discussed by Dr. Costa. And the one thing about allogeneic stem cell transplant that I'll touch on is that it still has a role. However, we need to clearly define what that role is, and that may be a little bit more difficult as we have more and more therapies that are not as toxic as allogeneic stem cell transplant for myeloma. So what do we know about auto transplant and novel agents? Well, I guess we'll take a historical perspective first. The CIBMTR data indicates that multiple myeloma still continues to be the #1 reason why patients undergo an autologous stem cell transplant. So for multiple myeloma and non-Hodgkin's lymphoma, that represents over 50%, nearing 60% of the autologous transplants done in this country. This data is updated since 2011, but there's indication that this continues to be the case. Transplant survival has improved with autologous transplant due to better supportive therapies, and when compared to results of allogeneic stem cell transplant, autologous transplant patients do much better. So the use of autologous transplant really came on the scene in the mid-90s when this publication, and I'm sure many of you have seen this drawing several times, that was published by the French myeloma group comparing high-dose chemotherapy with melphalan on autologous transplant to conventional chemotherapy, which at the time was vincristine-based VAD therapy. And in all patients, there was an improvement in overall survival, as well as improvement in overall survival in young patients. And what is not shown on this slide is there was also a vast improvement in progression-free survival when high-dose chemotherapy and autologous transplant was compared to conventional chemotherapy. Now, after the 90s, there were multiple trials that looked at transplant compared to standard dose cytotoxic chemotherapy. And this meta-analysis that was done in 2007 grouped together the available randomized controlled trials that were published up to that date. And multiple trials displayed an event-free survival benefit for transplant compared to standard therapy, but only 3 trials actually showed an overall survival benefit. If you look at these regimens, you'll see that they all contain regular cytotoxic chemotherapy. So after the mid-90s, there were new kids on the block, and this information, we weren't sure how relevant it was anymore. Grouping this meta-analysis, multiple studies, even though they didn't show statistical significance for improved overall and progression-free survival, certainly many of them favored improvement in overall survival, and also time away from treatment and improvement in symptoms while away from intense therapy. And that was what autologous transplant offered compared to continuous cytotoxic chemotherapy. That was true for overall survival as well as progression-free survival, a favoring and benefit of high-dose chemotherapy. So around 2008, By that time, we had available thalidomide, bortezomib, as well as lenalidomide. And this study done from the Mayo Clinic looked at groups of people that were studied at their institution and how they performed after the advent of novel therapy. So they took two groups of people. The top group is a smaller group of people. And what they noted that patients who relapsed their disease before 1998 actually had a shorter survival, understanding that they would not have the benefit of the novel agents. And patients who had relapsed disease later, after 2004 or 2005, actually had improved survival. They went to a larger data set of newly diagnosed patients and noted that from the time period that was evaluated, which was early 1970s to about 2006, patients that had exposure to the newest drugs, which are in this dotted line, had improved survival. So all of that correlated with increased use of stem cell transplant as well as increased use of novel agents. And it wasn't clear which of the two had the biggest impact on the better outcomes in myeloma. So this How to Treat or How I Treat article was published in Blood in 2009. And it grouped together multiple phase 2 and phase 3 trials that incorporated novel agents in myeloma. And here is where we get the popularity of the doublet and triplet regimens that are commonly used today. If you notice, the majority of these agents had an excellent overall survival, with the RVD and Cytoxan Velcade Dex regimens having excellent response, with RVD having 100% response rates, which in the era of standard dose chemotherapy, vincristine based, that was unprecedented. We did not get those types of results. However, we have to take caution. I think when this data came out, everyone said, oh, you don't need transplant anymore. However, there was no evidence to show that an early response to therapy really was going to equate to long-term disease control. So the question was not yet answered. And as you all know, multiple myeloma is a very complex disease. An accumulation of malignant cells in the bone marrow results in marrow suppression and deregulated immune globulin production. It's a multi-step process, starting from a benign clonal population of cells that undergo a series of cytogenetic changes and interaction with the intramedullary space to produce malignant behavior, and eventually evolves into systemic multiple myeloma, and in end stages, plasma cell leukemia, where it's no longer dependent on the bone marrow microenvironment to grow and can freely circulate in the bloodstream. So a series of genetic and epigenetic changes occur when multiple myeloma becomes multiple myeloma, and there's an increase in the intimacy of the multiple myeloma cell with the bone marrow stromal cell, resulting in release of a series of cytokines that increase the movement of the myeloma cell through the bone marrow space by increasing osteoclastogenesis as well as angiogenesis. The reason why our targeted therapy works so well is because these targeted therapies, which we call novel agents, interrupt emission of some of these cytokines as well as halting of the activity of many of the transcription factors that are involved in tumorigenesis. So it is clear that we have a better response when we target the myeloma cell in multiple ways, and we have not been successful at curing myeloma by only cytotoxic therapy. So we can't completely rid ourselves of this myeloma cell by just blasting it out. You have to attack it from multiple different angles. So we've become smarter about our analysis of myeloma cells and prognosis. We have looked at prognostic markers with karyotype and cytogenetic changes in fish. And as of late, there's more work that's done in gene microarray array and microRNA analysis. However, that's not yet standardized that we could use in common practice. So in this current era, and things are constantly changing, it appears as though the best way to approach myeloma is, again, from multiple angles, and use our treatment plan that parallels that of acute leukemia, in that we have an induction phase where patients are exposed to novel agents early. Stem cells are mobilized. Stem cell transplant is still part of the therapy, and now novel agents are incorporated after transplant in either a consolidative or maintenance fashion, and that is the current paradigm of how we treat myeloma. As a result, during this time, we've seen a steady increase in survival, and again, we have autologous transplant in the mid-90s, and then treatment after treatment after treatment, and now, as of 3 weeks ago, you can add panobinostat to the armamentarium of multiple myeloma. That's resulted in this steady increase in survival that is anticipated to continue to increase. However, still, we are unable to completely cure the disease. And Sagar Loniel presented this slide at ASCO in 2013 that gives an idea of why it may be difficult to kill the myeloma cell completely, but there's still always this hope that if we get deep enough and kill enough cells that we potentially can cure the disease. So here's our myeloma patient floating on the SS patient cruise liner, and they run into this iceberg, and when we see the patient, we're really only seeing the tip of the iceberg, and the rest of their disease burden is much deeper, with the idea that even when we achieve CR, or what we consider stringent CR, with normalization of free light chain, no apparent clonal cells in the bone marrow, no detectable paraprotein, there's still much more to the story. And of course we know there's more to the story because even patients that achieve stringent CR will relapse in time. So there's a question of getting to minimal residual disease, and there's several studies in minimal residual disease that show improved outcomes the more clearance of the myeloma cell line that you achieve. But that also has not been standardized across centers. So those are the things that we know. There's evidence that transplant works well for patients, chemotherapy era. I will give you more data about transplant in novel era. So why do we transplant in novel era? When should we transplant? And who should have a transplant is the next part of the discussion. Some doctors will say, everyone needs a transplant. Some doctors will say, only some patients need a transplant. And some doctors still will say, don't do any transplant on any myeloma patient unless there's nothing else to do. So this slide was presented by Donna Reese of the Princess Margaret Hospital in Toronto at ASCO 2013, where she reviewed post-transplant results using novel agents. They're not the same type of regimens, but they all incorporate one or two of the agents we consider to be novel. And also these particular trials use these agents after transplant in a consolidative fashion as well, which has been done in some instances, but also has not been standardized as far as when to do it, why to do it, who to do it for. So the gist of what she was trying to show is that when you add transplant to all of these regimens that use novel agents, patients at least get a greater than a partial remission, with roughly 20 to 60% of the patients increasing their remission to VGPR or CR. And that increase actually, it goes further if you use consolidative novel agents after the transplant. This trial, they went from a CR of 55 to 61% increase, and there is definitely an increase here. So the combination of transplant plus more novel therapy seems to be a good approach. So there are more people that are understanding that transplant, yes, has a role, but then the question comes, okay, well, does everyone have to have the transplant right away? Are there some patients that we can delay the transplant until a later period of time? Can we just collect the stem cells, freeze them, and use the transplant later for whatever reason? So as far as the question of early versus delayed transplant, there's actually no prospective randomized controlled trials that help us to make this decision. I think many of us as a medical community talk to the patient, and there have been a few publications that suggest that it can be okay, but we really don't have enough proof to offer this for patients. So there are two retrospective analyses that have been published that look at early versus delayed transplant. This was a study from the Mayo Clinic looking at few patients, and they designated early transplant as being performed within 12 months of diagnosis and delayed after 12 months. And they don't really declare what was the reasoning for the delay. So there's no way that we could know, and inherently that involves some type of bias in the study of why patients were delayed. But what they concluded was that there was essentially the same time to progression after transplant in those patients who actually went to transplant. And some of the patients that were included in this didn't go to transplant but had stem cells collected, so were considered transplant eligible and were counted on the transplant side. Then progression-free survival, there was apparently no statistical difference, and overall survival at 4 years seemed to be the same in both groups. But there are some issues with that study for us to really take with a grain of salt. So there's another retrospective analysis that was put out by Ohio University with the same cutoff as less than 12 months or greater than 12 months. And the reason for delay in the transplant in this group was stated to be delayed referral to the transplant center for whatever reason. We don't know. And again, if you look at the 1, 3, and 5 year overall survival, they're relatively the same, as well as median progression-free survival, they're relatively the same. So it fuels the question again, does it really matter when I do the transplant, early versus late? We really still don't have the answer, but we're getting to it. So this trial that was published by Palumbo, and he presented this at ASCO 2013, and then the publication came in the New England Journal of Medicine last year, where he looked at, or his group looked at 402 patients. They were younger than age 65, and they were randomized from multiple centers. They all started with the same novel agent induction, and then went on to fall into one of 4 arms. After RD, there was a group of patients that went on to receive more chemotherapy, and then the second arm went on to receive 2 courses of transplant. One of the group of the MPR went on to receive lenalidomide maintenance, and then a portion received no maintenance, and in the transplant group, a portion received lenalidomide maintenance, and then a portion received no maintenance. And the results, as published in 2014, indicate that when you look at, now this is what we've all been waiting for, is the results of auto transplant in the novel era, and it shows that this line, you may not be able to see it well, but as far as progression-free survival, this is the transplant results. And in 5-year overall survival, the transplant results also are improved. So this year, at ASH, there was another review of a transplant trial, and it used the premise of this type of paradox in the clinical trials looking at transplant and novel agents. So The Palumbo trial is here, and then this was an earlier trial that was published, I think in 2014 as well, but the patients were monitored earlier, where they looked at patients that were older and separated them in 3 different arms, 2 chemotherapy arms, and then this is a reduced intensity transplant arm. And if you can see, the lilac is a chemotherapy arm, and it looks to be improved. So this fueled a pooled analysis of 2 phase 2 trials looking at newly diagnosed patients, and compared transplant to chemotherapy followed with lenalidomide-based chemotherapy to look at progression-free survival in patients younger than age 65. There was also a plan to evaluate role of transplant as salvage therapy at relapse. However, many of the patients were unable to get salvage transplant due to multiple reasons, one being lack of fitness for the salvage chemotherapy at the time of relapse. So the question is there a subset of patients that we could identify that may do okay with chemotherapy early and delay transplant, or are there a group of patients that we shouldn't wait and we should go right ahead? And so this first trial is an Italian trial, and the next trial is the European Myeloma Group trial. Patients all received lenalidomide dexamethasone induction therapy followed by transplant versus chemo in one arm, then maintenance versus no maintenance, and in this European trial, transplant versus no transplant, maintenance versus no maintenance. And the patients had similar characteristics with the exception of a slightly higher stage 3 in the chemotherapy len arm, and less patients achieving VGPR in the transplant arm than the chemotherapy len arm at the time of after initial induction. So the results here show that the progression-free survival 1 with randomization to first progression show a benefit of the chemotherapy arm, the transplant arm compared to the chemotherapy arm, with a median progression-free survival of 41 months compared to 26 months. And then the PFS2, which is from randomization to the second progression, also shows a benefit of transplant when compared to lenalidomide-based chemotherapy. The overall survival was noted from time of randomization to death, and again, there was an improvement in 4-year overall survival in the transplant arm. So this is getting a little bit closer to answering the question of, is there still a role for transplant with novel agents? And it appears as though they're synergistic and one should not be replaced with the other. And so they looked at different subgroups, and the distinction continued to be in favor of transplant in low ISS stage, as well as normal cytogenetics or non-poor cytogenetics. But in the poor cytogenetics, there was not a statistical difference. It favored transplant, but not statistically different. So the conclusion of the investigators was that the melphalan actually improves progression-free survival 1, 2, and overall survival when compared to lenalidomide-based chemotherapy. The investigators, again, could not study autologous transplant as salvage therapy as they'd hoped because many patients weren't eligible. So the idea is if you wait for transplant, then your patient may not get the benefit of it. And the most benefit was seen in patients with good prognosis. It does not mean that bad prognosis patients should not get transplant. It just means we need more therapy. So I'm going to run out of time, so I'm going to skip ahead. This is basically just telling you that there was a debate at ASH about early transplant versus delayed transplant. And it was almost a boxing match, but there was no winner, and it still continues to be a circular argument with no answer, but we're getting closer. So we're all hoping that the answer will come with this phase 3 trial that we're currently enrolling patients at UAB, where everyone gets RVD chemotherapy and are randomized to either early transplant versus just stem cell collection. Early transplant. Early transplant is this arm, stem cell collection, and only do transplant at relapse. And look at multiple endpoints, including pharmacokinetics dynamics and as well as proteomic profiling. So myeloma is a complex disease, and one modality of therapy, there's not going to be one silver bullet that gets all of myeloma. There's this idea of clonal tiding, where myeloma cells, once we kill them, there's a clonal evolution and expansion of a more resistant clone with each line of therapy, to the point where we get to clones that cannot be reached with chemotherapy and get relapse refractory disease. And that tends to be the end story of everyone's myeloma, aside from few that we are able to cure with allogeneic stem cell transplant, but at a great cost. So what I tell patients is we start with a big vat of myeloma, and we do all these things to decrease the clones, but we have these small subdividing clones that are beneath the surface. And right now, we don't know how to decide who should go to transplant or not. We basically decide who goes to transplant based on fitness. It's not necessarily on biologic factors. And so the only thing that we could say is if patients have poor disease markers, we're going to be more apt to want them to have more aggressive therapy. But there's nothing really that we have available that says a person should not have a transplant. So there are disparate outcomes in multiple myeloma. There are transplant barriers. There's a constant struggle with sequencing of the many different agents that we have with multiple myeloma. And then there still leaves the question of who should have the risk of an allogeneic stem cell transplant. So I'll just talk about disparate outcomes and barriers, and I think I probably have 1 minute left. And so I'll try to talk about the most exciting things. I've already showed you this survival curve, and we know that there are high prognostic risk factors, and now we actually have some data from GenoRacquel. Definitely more subgroups that we can identify than these patients with poor cytogenetics and high risk profiles still continue to have a median survival of 2 to 3 years. So these patients we really need to do better. There's also a disparity in race in multiple myeloma, and interestingly enough, before the era of novel agent, the relative survival of African Americans in this country was actually better than Caucasian Americans, and with the advent of new therapy that flipped, which doesn't make much sense. It seems like everyone should do better, not worse. And so we know that there's an increase in incidence in myeloma when it comes to race. There's no indication that there's an increase worsened biology in myeloma. However, what we do know is from data from the SEER database analysis is that utilization of transplant is not as robust in African Americans or non-Hispanic whites. And the increase in 5-year survival that we have noted with all myeloma patients has also not been as robust in African Americans or Hispanics as it has been in non-Hispanic whites. And this actually continues to increase where these numbers are not moving at all. And so I'll move forward. This study was done by Dr. Costa, where he looked at a large number of patients in the CIBMTR database and noted that utilization of transplant from these time periods in African Americans really has not changed, and there's got to be a reason why. So in equal access systems, there's no indication that African Americans do worse with therapy. There's very little data about use with novel agents. A lot of these trials were from cytotoxic chemotherapy. This is a very small trial that actually indicates improved survival in African Americans, but again, this was a very small study in University of Chicago, and this is the closest we get to looking at the result of use of novel agents compared to race. And this single institution study, with a few more patients, we did note that the African American patients that were studied did not have as great a response to IMiD-based therapy as compared to their white counterparts, or IMiD plus proteasome inhibitor therapy. Now, this is not reproduced in every study. There are actually other studies that refute this. So there's more information that needs to be gathered. And again, just as in an analysis, looking at overall response, we see that there is improved response with novel agents compared to conventional chemotherapy in Caucasian, but the increase is not as apparent in African Americans. Okay, and so I know that I'm out of time, and so I'll try to bring the last points, just summarize them. But in that study, they did notice that there was a delay in referral for the African American patients, which wasn't clear. But there was no difference in median overall survival from the time of transplant. There was an increase in median survival from the time of diagnosis, and that may be due to being diagnosed at a younger age. So we need to improve utilization of transplant and novel therapies in certain subgroups of patients, but just improving novel therapy may not be the only answer. And we need to address why transplant is underutilized. So just to go quickly, Dr. Costa put together some information from the SEER 18 database looking at access to a transplant center by zip code distance, and separated these groups of the 45,000 patients depending on their distance that they live from a FACT-accredited facility. And essentially, the closer the patient, not the very closest group, but the survival was better in patients that lived closer to or had better access to a transplant center, and subsequently, or what we hypothesize is more complex clinical therapy than if they lived further away. And so there was a univariate analysis that identified distance from a transplant center as a major player, and then multivariate analysis was broken into two, where distance continued to be an important indicator of poor survival. And when income and education were added into the analysis, actually the distance was displaced. So higher household income and higher education actually displaced distance and did not make it as important a barrier. So he also put together this nice little cartoon. We spent a lot of time talking about different, more aggressive treatments and disease biology, but there's also a lot of other issues that come into play when treating the myeloma patient, and we need better tools to help eliminate the disparities that will aid our intervention in taking care of our patients. And as far as income goes, insurances, Medicare and Medicaid, have approved paying for transplants since 2000, but there are a lot of supportive costs that one cannot anticipate when they get this diagnosis. So that may be an area that could be helpful. So in the end, or future thoughts or goals of care, I guess these are all, holy grail or wish list for multiple myeloma, that we have improved progression-free survival, overall survival, address quality of life. Patients like the idea of increased time away from intense therapy that transplant offers and still offers. Even when the disease does not respond to other therapy, still melphalan as a cytotoxic chemotherapy can be effective, get good cell killing, and leave the patient time to be away from intense therapy. And there's an ongoing effort to decrease the gap of disparate outcomes. And I know I went over, and so thank you.